In today's video, I'd like to share some information about different types of sciatica, which was sparked by a conversation I had with a patient recently. He had a history of sciatica about 5 years ago and ended up having a discectomy. That's a surgical procedure to remove the fragments of the disc pressing on the nerve. And this produced a good resolution of symptoms. So he had a classic sciatic, severe and sciatic type of problem with nerve root compression that resolved with surgical decompression. He presented this time with pain in the buttock, and intermittent pain in the side of the knee and some cramping in the calves, and wasn't sure whether he needed a hip replacement, whether he damaged the knee, or whether he'd strained the calf. And systematic examination pretty quickly determined that the source of his symptoms was from the nerve root irritation, and that irritation was happening in the spine. And he was somewhat perplexed by that because he had no back pain. And this is a phenomenon we'd see quite frequently clinically, particularly in patients who've had a history of previous episodes of sciatica. And the reason why it can sometimes sneak in under the radar or sometimes not get recognized clinically is because there are different types of nerve root compression and different types of disc protrusions. And that largely is in a younger population. And I say that anything under 40, the disc material itself is a soft jelly-like material, which is quite elastic. And if that becomes damaged or bulges or protrudes or slips, as people will often refer to it, that causes pain in the disc as well as pain on the nerve that's being squashed. So in that situation, people will get their classic sciatic pain down the leg, but they will also get pain in the spine, and movements which put pressure on the sensitive disc are exquisitely sore. So they usually struggle to sit, to bend, to cough, to twist and turn. So that's usually the pattern that a younger person with an acute sciatica will describe. In an older person, and I say older, over 40, just as a general categorization, but it could be older than that, the disc material is no longer soft, springy-like material. It's a more rigid, crab-like material is how the surgeons often describe it, or a leathery, thickened tissue. So if that material is gradually compressing and narrowing the space for the nerve, very often the disc itself isn't sore. So people don't equate the symptoms that they're getting in the leg with their back, because they're used to equating back pain and leg pain if they've had sciatica. But in an older spine, the type of disc protrusion is a hard, bony material. I often describe it to patients, it's like the inside of a pipe getting furred up, or the scale on a kettle that you might find. It's a process that happens slowly over time, many, many months and years. And very often the nerve root can adapt to that quite easily until it reaches a critical point where the space for the nerve root just is not wide enough and it starts to get agitated. And that causes a problem, because if you cause some intermittent pressure on the nerve, it'll tend to swell just like any other tissue that's pressed or squashed. And of course, if it's trying to swell inside a very small space, well, then you just end up with more compression on the nerve. So it's usually a process that happens slowly over time, and then some event usually triggers it. Could be something trivial like, playing golf, or just lying in a certain position, or prolonged sitting or driving, or something along those lines that just drives it over the edge. And depending on the severity of compression on the nerve, in that older type of presentation, it's often patchy symptoms down the leg. In the case I just described to you there, pain maybe in the buttock or in the hamstring. Sometimes people feel that they've pulled or strained a hamstring, or they're getting cramps and spasms in often the calf is usually the common one. So that would indicate what you might call a more subtle degree of pressure, but it's still pressure on the nerve. On the more severe end of the scale, if that pressure gets much more marked, then you get full-blown nerve root compression problems, which are loss of power, or loss of sensation, loss of reflexes. And that's a serious issue, because you can't afford to leave that scenario for for many more than a few weeks if it's continuous, because you can end up having permanent damage on the nerve root, and even though it may be decompressed, the nerve doesn't fully recover. So it's very important for clinicians to recognize where people are on that scale. But in the context of what we're speaking about today, it's at the more subtle end. So we're not usually thinking about the surgical referral and scans, but it's important to recognize it, and clinicians need to be aware of it, because, as I say, patients usually equate soreness in their spine with their sciatic symptoms, and as things evolve slowly over time, the spinal pain usually isn't the feature, but it's usually pretty clear to identify whether the spine is causing the nerve root problems. So yeah, that's a sort of a more subtle nerve root irritation that sometimes sneaks under the radar, and the symptoms masquerade as other types of problems. But the hallmark of that is that when you systematically examine other areas where the symptoms are in the legs, in this case, we just don't find physical signs that indicate that the problem is in the hip or in the knee or in the musculature where people are feeling the symptoms. So it's not a local problem. So that's very important. Otherwise, people would end up treating the wrong tissue and not really identifying the underlying cause. Yeah, so that's a bit of an insight into the variation in severity of sciatica and the different kinds of presentations. So all sciatica just isn't created equally. So it's a phenomenon that the alert clinician needs to be tuned into. If you're in that small percentage of patients where physiotherapy isn't suitable or doesn't produce sufficient reduction in symptoms, and you need a surgical intervention, and then, as I've said several times before, that's about 10% of the sciatic population. But if you're in that bracket that need a surgical decompression, and we often have this conversation with patients that people would be apprehensive or would have heard negative stories about spinal surgery, but usually in that older patient with what we call osteophytic impingement, that's bone growth from a degenerate disc pinching the nerve, that responds very well to surgery if that's required, because it's really hard bony material that's being chipped away, which is much more predictable in its response than when you're trimming away soft, elastic, soft tissue in a younger spine, because you never really know how it's going to function after that tissue has been removed. Whereas in an older spine, it's much more predictable. So I often end up having that conversation with patients to try and allay their fears. It's not a conversation the surgeons ever get into, but it's certainly a phenomenon we would see very frequently and clinically, that the older spines do very well with decompression, as it's called. So it's not a procedure that one should undertake lightly, but it is a good procedure if it has to be done, and it doesn't have the connotations of failed back surgery, which seem to be a bit of an urban myth. So I just thought I'd share that information with you. I hope it's you found the information valuable. I'll see you again on another video. Bye for now.